Good morning, everyone. Welcome to this evidence review on the clinical approach to MRI-negative peripheral positional downbeat nystagmus, abbreviated as pDBN. For many years, pDBN elicited on Dix-Hallpike or straight head-hanging testing was regarded a red flag finding that usually signaled a central nervous system lesion. Classic teaching held that true CNS negative pDBN was exceedingly rare, perhaps only 0.1 to 0.2% of vertigo patients. A 2026 study from the Vertigo Center at Xiangya Third Hospital, China, challenges that now. Among 3083 consecutive patients evaluated for vertigo, 120, that constitutes 3.9%, had clear positional downbeat nystagmus, no spontaneous or gaze-evoked nystagmus upright, and a brain MRI showing no lesion that could explain the nystagmus. That is roughly 20 times higher than previously estimated. These authors propose a practical four-type classification based purely on the pattern of the nystagmus. U-DBN means a peripheral positional downbeat nystagmus, that is pDBN, that follows the upward beating nystagmus. The second is S-DBN, that is the single DBN. Third is mixed BN, mixed upward and downward beating nystagmus. And the fourth is C-DBN, continuous positional downbeat nystagmus, present in every position and never attenuating when the position is held. The first three subtypes behave like canalolithiasis variant of BPPV and respond very well to the carefully directed apply maneuver, 91 to 100% effective. Continuous pDBN, however, is the clear outlier. Only half of the patients tolerate or respond the repositioning maneuvers. Recurrence at 2 years is highest, and the underlying mechanism remains uncertain, possibly early central or functional disease like vestibular migraine. We will also examine the key differential from vestibular migraine, the surprisingly high rate of nystagmus switching during treatment, and a set of practical recommendations you can take straight into the clinic. So let's now begin. The title slide is Clinical Approach to MRI Negative Peripheral Positional Downbeat Nystagmus. From here in after, I will refer this as pDBN. Downbeat nystagmus on positional testing was assumed to be a red flag for the CNS disease. The classic teaching is that positional downbeat nystagmus (PDBN) evoked during Dix-Hallpike or straight head hanging test was long regarded as an extremely rare finding that usually signaled a central nervous system lesion. The emerging recognition is that a subset of patients who show PDBN with no responsible lesion on brain imaging, termed CNS-negative pDBN, the systemic description of this group has been limited. So the prior assumption was that 0.1 to 0.2% estimated incidence of CNS-negative pDBN amongst vertigo patients derived from anterior canal canalolithiasis and the BPPV prevalence. From this study, it was found that 3.9% of 3083 consecutive patients had MRI negative pDBN, roughly 20 times higher than expected. So the study at glance is 3083 vertigo patients screened at Vertigo Center Neurology Department, Xiangya Third Hospital from Feb 2022 to Jan 2024. 120 patients enrolled, which was 3.9%, pDBN on DHT or straight head hanging test, no spontaneous or gaze-evoked nystagmus, negative brain MRI. 137 cases of peripheral positional downbeat nystagmus reported. Some patients contributed more than one case, that means they had a bilateral disease or overlap types. 94 patients completed 2-year phone follow-up, that is the telephonic interviews. 6 were uncontactable, 5 declined, 15 did not answer. So there were dropouts of around 26. The inclusion criteria in this study, this is a retrospective study. included vertigo, dizziness, or postural instability. pDBN on Dix-Hallpike test or straight head hanging test. No spontaneous or gaze-evoked nystagmus in the upright position. CNS-negative implies that no imaging lesion accounting for the nystagmus. Testing for TST, RT, DHT, SSHT performed by one senior technician using SRM4 system. A new four-type classification of pDBN, first proposed classification scheme based on the nystagmus characteristics during the positional testing. No prior compatible reports are available. First is U-DBN, number 11, positional downbeat nystagmus following an upward beating nystagmus. The positional upbeating nystagmus or torsional upbeating nystagmus, immediately followed by a downbeating nystagmus or a torsional component DBN. Second is single pDBN, that is the S-DBN. 61 patients, only downbeat nystagmus or torsional nystagmus with downbeat component is seen on DHT or a straight head hanging test. Third is mixed beat nystagmus. The numbers were 32. Both upward and downward beating nystagmus occur on Dix-Hallpike test or straight head hanging test, not fitting the U-DBN pattern. And the third is continuous pDBN, that is C-DBN. All postures, that is the supine roll testing, the roll testing, then Dix-Hallpike test, then straight head hanging test, provoke downbeat nystagmus. Nystagmus persists without attenuation of the slow phase velocity. So the distribution across the four subtypes, the single DBN constituted 61 patients, almost 50%. The mixed beat nystagmus and continuous nystagmus DBN were around another 60%. So these are the clinical characteristics by the subtype. It is important to note that the continuous downbeat nystagmus C-DBN patients, 50% had effective repositioning maneuvers. So it is the least of all. 30% patients had hearing loss or tinnitus, and vertigo recurrence was highest, 45% in these patients of C-DBN. So this group looks slightly different from the other three groups. So the nystagmus characteristic by this subtype, the reading pattern from this table is that U-DBN brief latency transient classic BPPV signature despite the direction reversals, that is upbeat followed by downbeat. The single DBN usually no latency, roughly half transient and half persistent, that is the nystagmus lasting more than a minute. Still BPPV is associated. The continuous DBN, C-DBN, always persistent, provoked in every position and breaks the classic BPPV pattern. So choosing the repositioning direction, localization follows Ewald's first and third laws where possible. When localization is uncertain, the subtype dictates the default. So Ewald's based localization when torsional component is accessible. The torsional component when ipsilateral to the Dix-Hallpike test and weak, it was labeled as classified as ipsilateral anterior canal BPPV, and when it was strong, it was considered contralateral apogeotropic posterior canal BPPV. Torsional component contralateral to the Dix-Hallpike test, and if it is weak, it is contralateral anterior canal BPPV. If it is strong, it is ipsilateral apogeotropic posterior canal BPPV. So U-DBN default direction ipsilateral apply, same side as the co-occurring positional upbeating nystagmus. Mixed beating nystagmus default direction is ipsilateral apply, ipsilateral to the side of the mixed beating nystagmus, and default direction in the single DBN was contralateral apply, and the effectiveness of the U-DBN and S-DBN using this protocol was 100%, while in the ipsilateral apply and the mixed beat nystagmus it was 93.8%. In any case, the efficacy applied was more than 90% efficacy in all cases. So RPM repositioning maneuver effectiveness sharply diverges for the continuous DBN. Why C-DBN lacks? Only 48.3 patients with continuous downbeat nystagmus patients even allowed attempt of repositioning maneuver versus 98.4 to 100% in the other groups. Nystagmus is persistent in 100%, not the transient otolith typical pattern. Highest 2-year recurrence rates 45% and only group with the reported falls. This is very important. The fall risk is highest in patients who are having continuous downbeat nystagmus. So the nystagmus can switch in mid maneuver. 15.8% of patients, that is 19 out of 120, switched nystagmus during the repositioning maneuver. And this is in sharp contrast with 4.6% previously reported incidence by Wu et al. In 2022. The switch was important. It was switched to the horizontal nystagmus, that is switched to the horizontal canal BPPV. Then it was switched to the typical periampullary posterior semicircular canalolithiasis, and the two had a switch to the single downbeat nystagmus. The mixed beat nystagmus, they 2 out of 120 patients, they switched to the single downbeat nystagmus. What is the clinical implication or clinical take from it? Otoliths appear to move between canals during the maneuver. Re-examining the nystagmus after each repositioning step, and you should be ready to redirect the treatment. That is, continue with the barbecue roll or Guffoni maneuver if horizontal nystagmus appears, rather than concluding the therapy has failed. So, why the continuous downbeat nystagmus behaves differently and may not be BPPV at all? This is the spatial focus. 100% of C-DBN nystagmus is persistent versus 0 to 47.7% in the other groups. 48.3 of continuous downbeat nystagmus patients were willing to undergo RPM. So more than 50% they did not allow the repositioning maneuvers to take place. 48.9 had incidental MRI findings like the fasciicles, white matter changes, brain atrophy, and old infarcts. They may not be incidental, but certainly not responsible for the downbeat nystagmus. In 45%, there was 2-year recurrence, the highest of four groups with the reported falls. So, what is the working interpretation? MRI negative means no imaging lesion clearly responsible for the nystagmus, not the absence of any pathology. The authors caution against attributing continuous downbeat nystagmus simply to BPPV and raise the functional or early central causes like multiple system atrophy, cerebellar or spinocerebellar ataxia, particularly the newly emerged spinocerebellar ataxia type 27B, as differentials requiring longer follow-up. This slide is important. Vestibular migraine versus peripheral BPPV type positional downbeat nystagmus. This is important because vestibular migraine is also can present as positional vertigo. So features vestibular migraine versus peripheral BPPV type of upbeat or single DBN or mixed beat nystagmus. The disease course in vestibular migraine is recurrent with repeated episodes over time, while the peripheral BPPV type here U-DBN, S-DBN or mixed beat nystagmus is typically a single self-limiting episode. Key history clues: migraine history is there, other type of migraine headaches. If the oral symptoms are there, it is bilateral tinnitus and bilateral high frequency hearing impairment. While in the peripheral BPPV type, there it is recent onset, less than 15 days, no hearing loss pattern is seen. The latency in duration in vestibular migraine is usually no latency, where there is a very slow wave velocity of 2 to 10 degrees per second. Then the it lasts for more than 60 seconds without attenuation. While in the peripheral BPPV type of U-DBN, S-DBN or mixed BN, latency is variable by the subtype. The nystagmus is typically transient and attenuates. The directional or canal fit does not follow the anatomical rules of semicircular canals in cases of vestibular migraine because it is a central type of vertigo, while the peripheral BPPV type U-DBN, S-DBN and mixed BN follow the evolved law and it is localizable to a canal. Associated ocular signs in vestibular migraine, 70% they show saccadic dysfunction, 50 to 60% show type 3 smooth pursuit abnormalities, while in the peripheral BPPV type, usually none beyond the positional nystagmus itself. BPPV comorbidity in vestibular migraine, 18 to 20% of these patients also have BPPV versus 2 to 2.4 baseline. The peripheral PPPV type defines itself. Response to repositioning maneuver. The vestibular migraine may transiently improve. This is the central adaptation underlying the disorder persists. The peripheral BPPV type of U or S-BN or mixed BN effective in 91.6 to 100% of cases in this cohort. So clinical recommendations. Don't assume rarity. MRI-negative pDBN occurred in 3.9% of vertigo patients here, far more common than the historical 0.1 to 0.2 estimate. Consider it in the differential of positional vertigo. Number two, classify the nystagmus. Use the U-DBN, S-DBN, mixed BN, and C-DBN framework to anticipate the prognosis. The first three behave like BPPV, C-DBN does not. Third, choose the direction deliberately. Localize via the Evolt's law wherever possible. Default to the ipsilateral apply for U-DBN mixed beat nystagmus and contralateral apply for single downbeat nystagmus when localization is uncertain. Here I slightly differ for the contralateral DBN. So they imply that everything which is S-DBN is the anterior canal BPPV. I may tell you here that the apogeotropic posterior semicircular canal BPPV with downbeat nystagmus and with its three variants, namely the Shigano variant and the Califano 2021 variant and the classical Vanucci variant is 6 times more common compared to the anterior canal BPPV. Fourth, re-examine between the maneuvers. Nystagmus type switched in 15.8% of the patients during the repositioning maneuvers. Higher than prior reports, reassess and redirect. That is barbecue roll or Guffoni maneuver for the horizontal canal conversion rather than stopping it and labeling it as a failed maneuver. Treat vestibular migraine as a key mimic. A negative brain MRI does not exclude a central or functional disorder such as vestibular migraine. Screen the history and oculomotor signs. And if vestibular migraine is not a possibility, especially in the elder, look for the paraneoplastic causes. This is very important not to miss a neoplasm which may be developing within the human body. Flag and follow C-DBN closely. Persistent nystagmus, poor response to the repositioning maneuver in 50% and the highest 2-year recurrence rate warrants longer dynamic follow-up and vigilance for evolving CNS disease. So limitations to be kept in mind while interpreting the evidence. Number one, this is a retrospective single center observations design. Mechanistic hypotheses are not prospectively verified. Number two, MRI negative reflects the absence of clearly responsible lesion and not the normal vestibular CNS function. It does not include the functional disorders like vestibular migraine or else paraneoplastic disorders. Video head impulse testing and systemic audiological assessment were not consistently available, limiting the objective quantification of semicircular canal and cochlear involvement. Number four, follow-up was by telephone with 26 out of 120 patients, around 22% lost to 2-year follow-up. Very surprising, no mention of the treatment response or any apogeotropic posterior canal BPPV is there in the diagnosis in the publication, given that it is 6 times more common than the anterior canal BPPV. So, the future direction, prospective follow-up with the standardized audiological and vestibular function testing, including the video head impulse test to sharpen the mechanistic understanding and refine the treatment algorithm is required, and also to keep in mind that peripheral positional downbeat nystagmus, if it is peripheral only, could be apogeotropic posterior semicircular canal BPPV with its three variants very clearly defined over past 11 years. Paolo Vanucci defined the Vanucci variant, then came the Shigeno variant in 2020, and finally the Califano's periampullary variant of the apogeotropic posterior canal BPPV in year 2021. I finish my talk here. Thank you very much.